Due to this reason, in lumbar puncture, when you take the CSF sample, albumin level is high, but cells level, inflammatory cell is normal. Normally there are cells in CSF. Yeah, lymphocytes are there. A few lymphocytes you are allowed to have, but you are not allowed to have any neutrophil in the CSF, right? Am I clear? So normally what happens when there is inflammation in the central nervous system or inflammation of the meninges, protein levels go up along with inflammatory cells. So it means normally in most of the pathological processes which involve the central nervous system, when there is inflammation of central nervous system or there is inflammation of meninges, not only protein level goes high in the CSF, but inflammatory cells also jump into CSF. So normally what happen in the central nervous diseases, as protein level in CSF goes up, inflammatory cells level also go up. But this is an exception, Guillain-Barré syndrome, in which proteins level in the CSF goes up, but inflammatory cell level does not go up. So this type of feature is called albuminocytologic dissociation. Normally when albumin should go up, inflammatory cell should also go up if disease process is involving meninges directly or CNS. But because in this process nerve roots are involved and they provide little bit excessive amount of proteins into subarachnoid space, but they don't let lot of inflammatory cells to escape into CSF. So we say there is, yes, what is the problem here? Albuminocytological dissociation. Because first you should know what is albuminocytological association. That what is the concept of albuminocytological association in CSF is that whenever albumin in CSF goes up due to inflammatory process, along with that inflammatory cells level also go up. But Guillain-Barré syndrome is an exception in which albumin level in the CSF goes up, but cytological level, or you can say lymphocyte level or other inflammatory cells level is not going up. Due to that reason, we say that in Guillain-Barré syndrome, even though it's peripheral, demyelinating, segmental neuropathy, which is post-infectious, cell-mediated, ascending paralysis is a very typical presentation, right? In this case, CSF albumin is high, but inflammatory cells are not there, right? After this, we come to another patient, and in this patient, we have one more problem, and the problem here is, okay, this is spinal cord. Okay, can you tell me the name of condition which is the most common hereditary peripheral neuropathy? Question goes to Dr. Ali. What is the most common hereditary polyneuropathy? Is that right? Question is what? Hereditary polyneuropathy, which may involve motor nerves and even sensory nerve. Is that right? Yes, who is going to tell me? What is most common inherited neuropathy? Anyone, feel free. Of course, it's not neuropathy. It is central nervous system problem. Yeah. What is the most common hereditary peripheral neuropathy? At least you should know the name of the most common. Yeah? Okay, transverse myelitis is inflammation of the spinal cord. We are talking about neuropathy. You are trying to confuse me, or yeah? Vitamin deficiency is inherited. I heard it first time, yes. Guillain-Barré is inherited, you mean? It is not inherited. What is the most common inherited peripheral neuropathy? Any one of you? Then he will say trauma. And maybe some families are generation after generation suffering a lot with trauma. Right? Yes, who is going to tell me? There's a funny name. This condition is called Charcos-Marie Tooth. Charcos-Marie Tooth. Charcos or Charcot, M-A-R-I-E, tooth disease. Charcot's Marie tooth disease. This is most commonly involved peroneal nerve, even though other nerves may be involved, but most commonly it involves peroneal nerve. So it is also called peroneal muscular atrophy. This is the most common inherited neuropathy, right? It may involve anterior motor neurons as well. So it leads to lower motor neuron type of problems or upper motor neuron type of problems. And it sometimes may involve dorsal column sensations as well. Write it down. This has the problem related with the motor system as well as has the problem related with the sensory system, right? This is an inherited problem. Then motor nerves and sensory nerves are not stable, right? So now again, let me repeat it. Let's recap. A person comes, he has all the dorsal root problems and dorsal root sensations are increased. There's increased pain, there's hyperesthesias, hyperalgesias and hyperreflexias, irritative lesion, dorsal root. Another patient comes and there's irritation to the anterior root. Okay, we did not discuss in our diagram, but there's irritation to the anterior root. If there is irritation to the anterior root, then nerve which is supplying a particular muscle, that will have excessive action potentials and muscle will develop spasticity. But without other features of upper motor neuron disease, if you irritate the anterior root, okay, we can make that also situation. Patient number 16. In this case, what really happens that there is irritative lesion and this irritative lesion is irritating the anterior root. Remember, irritative lesions increase the action potential in a neurological tissue and destructive lesions decrease the action potential in a particular neurologic tissue, right? And if there is irritative lesion, then the muscle which is supplied by this anterior root, that will undergo spasticity. It's very common when someone has a disc herniation, right? Disc herniation, okay, we'll go to the next patient. First we are talking about only a condition in which there was irritative lesion to the anterior root, right? Let me repeat out of these, then we'll go to the some other conditions. First, a patient comes and at C5 and 6 level, all the dorsal column sensations and anterolateral sensations are lost and there is areflexia, destructive lesion of the dorsal root. Another patient comes and there is severe pain, hyperalgesias in the C5, C6 level, irritative lesion. Another patient comes, he is having ascending polyneuropathy in which there is ascending paralysis, ascending symmetric paralysis. What will happen to this person? Albumin will be high in his CSF or cells? Albumin only. Is that right? We call this condition albuminocytological dissociation. This is a hallmark of which disease? Guillain-Barré syndrome. Then we come to another patient in which there is a family history of neuropathies and especially peroneal nerves are especially very commonly you can say having lower motor neuron type of lesion. Along with that, some sensory abnormalities are also there. What is the condition? Charcot's Marie tooth disease. Another person that he is having, let's suppose, quadriceps spastic, and there is some lesion which is irritating some roots. Which roots should be those? Anterior roots or posterior root? Anterior root. And which roots should be those? L2, 3, 4 most probably. Is that right? Now after having this exercise, let's go to patient number 17, right? Now we come to intervertebral disc herniation concept. You know, in between the vertebral bodies, there are intervertebral discs which act as shock absorbers. and these intervertebral discs are having a peripheral ring of fibrous tissue which is called annulus fibrosus, and within that they have a soft pulp which is called nucleus pulposus, right? Let's see that. It was patient number number 17. What we really see here, that this is a vertebral body, vertebral canal, spine, this is your vertebral body. Where is the spinal cord? Spinal cord is present somewhere here. Right? Here is spinal cord. This is vertebral body. Is that right? And of course, there is another vertebra above that, and so on and so forth. Here in the vertebral body, there is a intervertebral disc present, and this disc is made of fibrous collagenous ring, and this fibrous collagenous ring is called annulus fibrosus, and within this annulus fibrosus here is remnants of notochord which are also called nucleus pulposus. At the same time, you must know, here there is, what is this? Dorsal root, and here it is ventral root, and they make trunk, then dorsal and ventral ramus. Here also that there is, what is it? Dorsal root, ventral root, trunk, and here should be dorsal and here should be ventral ramus. Am I clear? Now, sometimes in some people the annulus fibrosus become weak. The most common site where annulus fibrosus become weak is dorsolateral side, and from here it starts protruding, a herniating disc herniation we call it, backward, right? And nucleus pulposus may be producing a pressure over there, right? Rarely it may be median problem, right? This type of problem may be precipitated with special mechanical stresses on the spine, excessive bending or twisting, right, which really puts a lot of pressure on the fibrous annulus which is present in between the vertebral body, and if there is some weakened point within this annulus ring, then nucleus pulposus may push a way out, and it is quite possible that either it more commonly posterolaterally, it's posterolateral. Most common point, please correct it, this is posterolateral. So it will herniate back into posterolateral direction, and the posterolateral direction they may go back and irritate the anterior root, or they also irritate the posterior root, or simply they irritate the trunk in the intervertebral foramen. Now, this situation is called, what is it called? Intervertebral disc herniation. Intervertebral disc herniation. Clinically, it is most commonly found at 2 points around the C6 and around the L5. It means the most commonly these problems may occur between L4 and 5, lumbar 4 and 5, or disc between 5 and 6, or in cervical region 90% cases are around this area and 10% cases are in cervical region, disc herniations. So most commonly they will be seen these problems around L5, right? That is either the disc between the L4 and 5 is disturbed, or disc between the L5 and 6 is disturbed. L5 and S1 is disturbed, yes, and the cervical region, right, 10% chances. Here what really happens that either disc which is above the C6 is disturbed, or disc which is below the C6 is disturbed. Now, what kind of clinical features will be presented in these patients? It's very easy to understand. There is irritation to the ventral root and dorsal root. And initially there is irritation, and eventually if you don't manage the patient well and disease become very much strong pressure there, it may lead to degenerative changes again. Initially when there is herniation, it irritates the nerve roots, but if it become prolonged problem, it may lead to degeneration of the roots. Usually these patients come when there is irritation, we call that there is spinal root symptoms. What are the symptoms? Spinal root symptom. For example, there is severe and chronic low back pain and leg pain. Along with the pain, there may be paresthesias. And eventually there may be sensory losses with hyperreflexia. The nerve root which has irritated initially, motor fibers, that may lead to spasticity of the muscles innervated, and eventually it may lead to flaccidity of muscle, because when it is irritating this anterior root, there is excessive action potential go through the anterior root, so there will be spasticity of muscle. But if keep on disturbing the anterior root and eventually destroy the anterior root, that will lead to flaccidity and mass loss of the lower motor neuron type of lesion of a particular muscle. Then one more condition which is present over there is similar, but in one way it is different. This is another patient, and in this particular patient, suppose this is cervical vertebra. Of course, again spinal cord is present over here. Now, here problem is not mainly with the disc, problem is with the bones, that these bones may make, you can say, osteophytes. Or if there is disc, then part of the disc become inappropriately calcified. They become inappropriately calcified, and these processes, when they go backward, right, this is more common in cervical region. In the cervical region, the degenerative changes in vertebra and the degenerative changes in the disc. But in this case, what really happens, from degenerative part of the bone, there is development of abnormal bone which are called osteophytes. Or if there is some degenerated part of the disc is not herniating in this case, rather disc part become calcified, and these pathologically calcified masses press the nerve roots and spinal cord. They press the nerve root and spinal cord. This situation is called cervical spondylosis with myelopathy. Cervical spondylosis with myelopathy. Cervical spondylosis with myelopathy. It is the most common type of myelopathy. Myelopathy means pathology with the spinal cord. So this is the most common type of myelopathy. So what is the most common type of myelopathy? Cervical spondylosis leading to myelopathy. Yeah. No, actually in the lumbar region, the intervertebral disc area is very much, right, and there are bigger areas from where the nerves are going out. So to involve there, it has to be a big protrusion of, you can say, disc which will go there. In cervical region, intervertebral discs are thin and bones are very near to the neuronal tissue. So little bit development of degenerative process, when a part of the bone becomes degenerated, then it abnormally grows, right, and that makes osteophytes. But because in cervical region the distance between the neuronal tissue and bony tissue is very less, so it's very easily involved over there. Secondly, overall degenerative changes are seen more commonly in the cervical region as compared to lumbar region, right. So what I was talking about, this is the most commonly observed myelopathy, and in this case not only anterior and posterior spinal roots or trunks are involved, but there may also be inappropriate pressure applied on the cervical spinal cord as well. Usually this is calcified disc or abnormal bony protrusions which are called osteophytes, right? In this particular patient, he will complain of painful stiff neck. Neck is stiff. Why neck is stiff? It's difficult to produce the range of movement, and muscles are also spastic due to irritation to the motor fibers. With that, there may be arm pain, irritative lesion. The nerves which are going to the arm are going to the brachial plexus. There may be arm pain and even weakness of the arm if there is a prolonged compression of the ventral roots. Now, this is a very interesting situation, unfortunately sad as well. When this process will move towards the spinal cord, of course from here motor fibers were going out and here it was sensory fibers. Now, what really happens in these patients, that even though nerve root problems are there and trunk problems are there, but this process also involves the spinal cord. And if this process becomes too advanced, it will move towards the spinal cord. It may interrupt corticospinal pathways which are going towards the leg, right? They may interrupt the, what are these pathways? Yeah, corticospinal pathways. And if this corticospinal pathway are affected, it means upper limb will develop lower motor neuron type of problems and lower limbs will develop upper motor neuron type of problem. So sometimes it happens that these patients have, in the cervical region, there is a pathology that bony osteophytes or calcified part of the disc compress anterior and dorsal roots coming out, and with that they may involve the spinal cord as well, and initially they involve the anterior part of the spinal cord, so anterior horn cells are degenerating, but eventually they, if disease become more progressive and not managed, then it may involve the lateral part of spinal cord as well. So in upper limb you may come across in severe cases lower motor neuron type of lesions, right, because upper limbs outputs, motor outputs are directly affected, but lower limbs lumbar output is okay, but their higher control which was passing through the cervical cord, that has been interrupted. So lower motor neurons which are present in the lumbar region which are controlling the lower limbs, they may lose the influence of corticospinal descending pathways due to compression in cervical region, and that may eventually end up into lower motor neuron type of lesions upper motor neuron type of lesions in lower limb. So this patient may have, yes, hypertonia, hyperreflexia, spasticity in the lower limb, and hypotonia, hyporeflexia and flaccidity into upper limbs, right? Now we are going to talk about hemisection of spinal cord. And when we talk about the hemisection of spinal cord, the all clinical presentation which is produced, that is also called Brown-Sequard syndrome. Now, in case of hemisection of spinal cord, let's suppose problem is half of the spinal cord is gone, right? It's all disturbed. Now we have to go according to the lesions. As you know that dorsal columns are interrupted. What should be the problem? Ipsilateral loss of dorsal column sensations, right? It means there will be loss of tactile discrimination, vibration and position with fine touch. Then here was, what are these two? Dorsal and ventral spinocerebellar tract. Dorsal spinocerebellar tract should produce ipsilateral lower limb dystaxia, and ventral spinocerebellar tract should produce contralateral lower limb dystaxia. With that, there is lateral spinothalamic tract. When this is damaged, there is contralateral loss of pain and temperature one segment below the lesion, and then there is anterior spinothalamic tract, that will lead to contralateral loss of crude touch and pressure 3-4 segments below the lesion. Then after these descending tracts, important ascending tracks. Important descending track is your corticospinal, and here it was anterior corticospinal, here it is, these are descending down, lateral corticospinal. Now, when there is hemisection of spinal cord, then descending tract which is interrupted here, then below the level of Leon, there are what type of motor problems? Upper motor neuron type of problems. It means below the level of Leon, there is spasticity, there is hypertonia or spasticity, with that hyperreflexia, ipsilateral of course, right, if it is, because already the system is crossed, is that right? Hyperreflexia is there and Babinski is upgoing, right, and there's slight loss of mass and power. Now another thing, that lower motor neurons at the level of the Leon which were exiting out, they are also injured. So what will happen? Lower motor neuron type of Leon at the right. So what really happens, where there is hemisection, for example it is C5, C6, then all muscles which are innervated by C5, C6, they have ipsilateral muscles showing the flaccidity, severe loss of mass, hypotonia, hyporeflexia, right, fibrillation, then fasciculations. And below the C5 and C6 level, all the segments will show upper motor neuron type of Leon. Another thing which you have to talk about is that all the sensory input is lost at the level of Leon. So we will say at the level of Leon there is lower motor neuron type of disturbance, and at the level of Leon there is complete anesthesia. All the dorsal column sensation and anterolateral sensations, they are lost, right. So at C5, C6 segments there will be loss of all the pain and temperature, vibration, position and 2-point discrimination. So what we will say, complete anesthesia at the level of Leon, right, and there will be lower motor neurons at the level of Leon, lower motor neuron type of problem in the muscle, and below the level of Leon, ipsilaterally there will be spasticity, and below the level of Leon, ipsilaterally there will be dorsal column sensation loss, and contralaterally there will be anterolateral sensations loss, right. Along with that, one point which should be highlighted, if this Leon is involving T1 and T2 areas, it means nucleus of Budge which gives supply, sympathetic supply to the eyes, that is also affected, and under those circumstances, if T1 and T2 are involved in this hemisection, then sympathetic supply to the eye is lost and patient will have ipsilateral Horner syndrome. You know, sympathetic supply to the eye produces pupillodilatation, so pupillodilatation is lost, and third nerve produce pupilloconstriction. So pupil will be constricted with partial ptosis, meiosis with partial ptosis, apparent anophthalmos and anhydrosis on the face, loss of sweating in the half of the face, right. Now we come to the complete section of the spinal cord, that is too easy to talk about. Can complete section of spinal cord produce death? It can do if it is very, very high Leons. Is that right? First thing which is very important, specific problems, that if Leon is somewhere between, it was 20th case, and if we have a Leon at, let's suppose C1 to, there is transection of spinal cord as C1 to 3, C1, C2, C3, we call it exitus lethalis, because when you damage over here, death is there, exitus lethalis, this condition is called, right, because just above there is medulla, and most important vasomotor and respiratory and inspiratory, all supply is coming over there. If that is interrupted to the rest of the body, death may occur, right. Then case number 21, again complete transection of spinal cord. Here it was hemisection, or Brown-Séquard syndrome. Here it is complete transection at C1 to C3, and next case is complete transection slightly lower level, let's suppose C4 and 5. C4 and 5 will affect the upper limbs as well as lower limbs. If you have transaction, upper motor neuron control of the upper limbs and lower limbs both are lost. So patient will have quadriplegia. Patient will have quadriplegia. And if lesion is below that, for example, below T1, then it means brachial plexus is intact, right? So upper limbs are okay, problem is with the lower limb, right? Of course, if whole spinal cord is transected at T1 or T2 level, then lower limb will lose the control of upper motor neuron, right? And that situation is called spastic paraplegia. That is called spastic paraplegia. There are many other features also, but right now first concentrate on complete spinal cord transection and important levels. If complete transection is very high, that may lead to death. If below than that, that will produce quadriplegia. If still lower than that, then it will produce paraplegia. Is that clear? Then other problems related with the, if patient survive, of course, what type of motor neuron loss will be below the level of lesion? Upper motor neuron. So if patient survives, then below the level of lesion in the transection, there will be spastic paralysis. Number one. Of spastic paralysis means there will be hyperreflexia also, there will be hypertonia also, and Babinski's will be downgoing, upgoing. Upgoing, Babinski's will be there, right? Then complete anesthesia below the level of lesion. All the dorsal column sensations bilaterally and all the anterolateral sensations bilaterally are lost below the level of complete transection. And another problem is that if spinal cord is completely transected, then not only upper motor neuron type of lesion problem is with the skeletal muscle, but problems are also with the visceral muscles, right? In that cases, rectum and the urinary bladder, right, that will lead to incontinence, right? So we can say there will be urinary and fecal incontinence with reflex emptying, Then of course, if complete transection of spinal cord is there, do you think vasomotor fibers are going down? Autonomic fibers, so that may lead to anhidrosis and loss of vasomotor tone below the level of lesion. And there is no fun in telling that of course you will lose your voluntary controls below the level of lesion, right? And if transection is above C5, you know, phrenic nerve is 3, 4, 5. Phrenic nerve supplies the diaphragm is C3, 4, 5. The level is above that, respiratory system will be also endangered, right? Now this was easy to understand. When we talk about the complete transection of spinal cord, first of all, three important concepts. If it is extremely high level, it will lead to death, C1, 2, 3. Then just below that, C4 and below, right, that may produce quadriplegia. If just further below, that upper limbs are spared and lower limbs suffer, then it is paraplegia. With that, then remaining section anywhere in the spinal cord, that will produce complete loss of sensations bilaterally, that will lead to bilateral spastic paralysis or upper motor neuron type of complications on bilaterally below the level of lesions, right? And with that, if T1, T2 are involved, Horner syndrome may be there. Is that right? In Brown-Séquard quad, this is unilateral, and in case of a complete transection, it may be bilateral Horner, right? And then of course about the viscera, rectum and the urinary bladder, there may be reflex emptying, but voluntary control is lost on the viscera, right? After that we come to one more situation. Next patient number 23. In next patient, there is loss of blood supply due to interruption of anterior spinal artery. You know, there are many arteries which supply the spinal cord, and out of those, there are two groups very important. If this is your spinal cord, Here is anterior spinal artery, right? And here are posterior spinal arteries. Then there are some arteries from the sides which are coming. Now anterior spinal artery supplies interior 2/3 of the spinal cord. It supplies interior 2/3 of the spinal cord. This is the supply pattern of the anterior spinal artery. Now, if due to some reason, let's suppose there's thrombosis or there's some other big problem with the anterior spinal artery, right, and it failed to supply interior 2/3 of the spinal cord, right, in a particular segment, then actually this interior 2/3 of the spinal cord will undergo degeneration or infarction. Is that right? Now, what will be the clinical feature in this? It's very easy to infer now. Why? Because posterior columns are spared, right, and anterolateral system is suffering too much. Motor system is, especially in this area, lower motor neurons which are outgoing at the level of lesion, they are suffering too much. Let's take one by one. In ventral artery occlusion or anterior spinal artery occlusion, number one, there is infarction of anterior 2/3 of the spinal cord. Number two, it leads to sparing of dorsal column and dorsal horn. What is spared? Dorsal columns and dorsal horn. They keep on functioning because they are supplied by other arteries, right? Now what really happens? Due to ventral horn destruction, at the level of lesion, there will be lower motor neuron type of problems, and below the level of lesion, there will be upper motor neuron type of problem. Do you think it's difficult to understand? When in a spinal cord, let's suppose here is a spinal cord and this piece, anterior 2/3, here it is degenerated, this area, right? What really happens? Here the lower motor neurons are lost, and whatever upper motor neuron was supposed to go down, they are also lost in this area. So we can say, as far as motor activities are concerned, at the level of lesion, patient shows lower motor neuron type of problems with the muscles, and below the level of lesions, there are upper motor neuron type of lesions. Then spinothalamic tracts are transected. It means, yes, this bilateral loss of pain and temperature below the level of lesion. This bilateral loss of pain and temperature, as well as this bilateral loss of crude touch. It means anterior spinothalamic or anterolateral sensations are lost, because anterior spinothalamic and lateral spinothalamic, both tracts are lost. Then dorsal spinocerebellar and ventral spinocerebellar systems are also disturbed, right? It means there should be bilateral dystaxia, but usually it is impaired due to upper motor neuron spasticity. Is that right? And another important thing, if lesion is very high, it may produce bilateral Horner syndrome, especially when lesion involve T1 and T2 level, or T1 which is having the nucleus of Budge. Is there any problem? Again, let me recap. If a patient comes to you, his dorsal column functions are perfectly okay, but anterolateral sensations are lost. With that, at the level of lesion, there are lower motor neuron problems, and below the level of lesion, there is upper motor neuron problems. You must think of anterior spinal artery occlusion. Anterior spinal artery occlusion. After this, what was the number of this patient? 23rd. Now we go to another group of problems related with the spinal cord. Let's go to lower level of spinal cord and see what happens to the patient if lower level of the spinal cord is disturbed. Now when we talk about this, Now the lowermost part of the spinal cord, this is called, what is this called? Not chorda equina, conus medullaris. Chorda equina is not spinal cord, right? What is this? Conus medullaris, right? And from the lower part of the spinal cord, there are a lot of roots which are coming out, and these are going down, and they are making a bundle of, you can say, anterior and dorsal roots, and they are going from different levels out, and this bunch is called chorda equina. And below this there is phylum terminale, which anchors it with the lower part of dura mater, right? Now we have to see, there are 3-4 syndromes related with this area. If there is a damage to this area, tip of it, this is called, yes, if damage is there, we call it epiconus syndrome. What we call it? Just at the tip, which is S3 to, for example, this lesion number 1 is S3 to coccygeal 0, it is lowermost, and this is called, which is S3 and C0, this is your, not epiconus, conus syndrome. What we call it? It is at the cone, conus syndrome, conus medullaris syndrome. But if lesion is above that, we call it epiconus syndrome, right? Slightly above that, we call it epiconus syndrome. It extends from L4 to S2, and we call it epiconus syndrome, right? Here you are having conus syndrome, conus medullaris syndrome, and above that there is, yes please, epiconus syndrome. These are both median lesions. Then lowermost here, if this part, what is this? Phylum terminale. If terminale become thickened and it become retracted and unduly pull the lower part of spinal cord, right? Then this syndrome is called, yes please, this is called phylum terminale syndrome. Phylum, I will explain all of them clinically as well. Phylum terminale syndrome. In this case, spinal cord is tethered, right? In some patients. Now these are 3 median syndromes. Let's start with the very lower level. If phylum terminale become thickened, fibrotic and shrunken and unduly pull the lower part of the spinal cord, what is this? Phylum terminale syndrome. If there is some median lesions, the lowermost part of the spinal cord, what is this? Conus syndrome. And if the median lesion slightly above that, what is it? Epiconus syndrome. And then of course we should not forget that if lesion is on the side, right? Lesion is on the side, and then this is called, what is it? Chorda equina syndrome. The art of understanding these syndrome is, you must know how they differ from each other, not only in location of lesion but clinically as well. Is that right? Now we'll try to go logically how these situations can be different from each other. First we'll talk about phylum terminale syndrome, then conus medullaris syndrome, then there is, let's change the name, okay? Phylum terminale is case number 1. What is this? Conus medullaris is case number 2 in this case, and here it is case number 3, and eventually this is case number 4. Again, phylum terminale, let's go into detail of this. What's there? You know, phylum terminale is actually pia mater thickening at the lowermost part of the spinal cord, which extends from there to the dura mater and help the lower part of spinal cord to anchor with the dura mater. In some patients, unfortunately, this becomes thickened and it becomes shortened, right? And this becomes adherent to the sacrum. You know, sacrum is just posteriorly to it, and it becomes adherent to the sacrum and causes undue traction on the lower part of spinal cord. What is pathology? Undue traction, undue pull on the lower part of spinal cord. Now, what will be the result? Lower part of the spinal cord is concerned with sphincter function, control of the sphincters, so there will be sphincter dysfunction. One clinical problem will be there will be sphincter dysfunction. Second will be there will be gait disorders. Both feet will not be able to work well because their lower motor neuron and upper motor neurons are not interacting normally, right? Because the end of the spinal cord is pulled down. And third, because the chronic problem with the musculature controlling the feet, so patient may develop bilateral foot abnormalities or deformities. Bilateral foot deformities. Again, let me repeat it. If phylum terminale become thickened, shortened, and posteriorly sticking to sacrum, then what really happens? That this phylum terminale, right? This phylum terminale becomes produces undue traction on the lower part of spinal cord. Lower part of the spinal cord is concerned with the control of sphincter, control of gait, and control of the tone around the foot. So when they have chronic problem with the tone around the foot deformities are there, then again gait problems are there, bilateral gait problems, and of course sphincter disturbances. Now we come slightly upward, right? If lesion is present in the, what is this area? Conus medullaris. If lesion is present in conus medullaris, S3 to C0. Here there is intramedullary tumor or metastasis, the primary tumor in intramedullary region, or the metastasis, or the hemorrhagic infarct. You know, from this area there is outflow of sacral parasympathetic. So this may lead to, when parasympathetic outflow is disturbed, you know, S2, 3, 4 is the parasympathetic outflow going to the last part of the GIT and urinary bladder. So parasympathetic outflow is disturbed, conus medullaris syndrome, and that may lead to paralytic bladder with fecal incontinence and in males impotence. With that, you know, the sensory input which was coming to the lower part of the spinal cord, it was coming around the anogenital area, saddle shaped area, right? For example, S3 or S2, or you can say coccygeal area, all this area receives the sensation from genital area, saddle shape area, right? So patient has bilateral saddle shape area, complete anesthesia, all the sensations are lost, right? Sensation around the anus and around the genital area is lost bilaterally. But extremely important point, because this lesion is not extending upward, and from here the output going to the lower limbs, so lower limbs are spared. This is the real differentiation between you can say conus medullaris and epiconus syndrome. That in epiconus syndrome, lower limb motor supply is interrupted, and in conus medullaris syndrome, lower limb are spared, right? So if a patient come and patient is having, you can say, sphincter disturbances and saddle anesthesia, but no lower limb abnormalities, it means this is conus medullaris. But if all these things, whatever they are, along with that lower limbs are also disturbed, then what is it? Epiconus. So do you think you need to go into detail of epiconus? Epiconus will have all those things which are present in conus, right? But the only thing is that lower limbs will be also involved, right? After that, another thing, look, when there is epiconus problem, number one, lower limbs outflow is involved, sensory motor problems are involved. Number two, if this area is functioning well, it means sphincter control is lost, the upper motor neuron control, but reflex sphincter emptying can be possible, reflex visceral activity is possible. For example, when rectum becomes full, it evacuates on its own. A bladder become full, it evacuates on its own. If lesion is at upper level, because lower motor neurons of the parasympathetic nervous system are alive here. But if there is conus medullaris, then parasympathetic outflow itself is having injury. So muscles become totally, the urinary bladder will become paralytic. And if lesion is above, then urinary bladder will become spastic. You know, as there were skeletal muscles, upper motor neuron and lower motor neuron lesion, the same way in urinary bladder and last part of the GIT can have upper motor neuron type and lower motor neuron type of problems. Let me repeat it. If you, from here, there was supply going to the sphincter. If this is damaged, it means sphincter have no control at all. Is that right? We say paralytic problem with the urinary bladder and paralytic problem with the rectum and anus. Is that right? In this case, you can say this is something now. But if this area is working well, but lesion is above, it means local reflex arches are working, but their higher control is lost. So reflex evacuation by the viscera is possible, but otherwise voluntary control is lost. Now again, let me tell you the difference in these two, because they confuse the student a lot. Both of them are median problem with the lower part of spinal cord. In one case lower limbs are involved, other case lower limbs are not involved. Is that right? If lower limbs are involved and sphincters are having spasticity, then it is epiconus. And if lower limbs are not involved and sphincters are having flaccidity, then it is conus. Is that right? Then we come to the fourth, cauda equina syndrome. It's easy to understand. The big thing is that it is unilateral problem, not bilateral problem. Cauda equina is usually lateral lesion, some tumor from the lateral side is coming, or there is intervertebral disc in a big way, compressing multiple sensory and motor roots in right or left cauda equina part, right? So usually this patient has clinical features predominating on one side. But phylum terminale problem, conus medullaris problem and epiconus problem, they were all having bilateral trouble. They were having all bilateral trouble. But cauda equina has which problems? Unilateral in a dominant way, right? Usually there is a intervertebral disc herniation which is too massive, or there is some tumor from the side and which is impinging on the cauda equina. In cauda equina, what really happens that when sensory nerves are irritated, that may produce intense radicular pain or root pain, right? Other features you can understand very clearly, that there are sensory roots as well as motor roots. So naturally first irritative problems are there and eventually destructive. In irritative problem, muscles will become spastic and there will be hyperalgesias and hyperesthesias. And when it becomes destructive, there will be anesthesias and muscle will become flaccid. Is that right? Phylum terminale syndrome was our 24th case, right, where there was mainly gait problems and sphincter problems. Then conus medullaris was our total 25th case, in which there was a sphincter problem, especially the viscera had paralytic dysfunction, right, and lower limbs are spared. And when you go for epiconus syndrome, then what really happens? Sphincters are having what type of problem? Spastic type of problems, and reflex emptying is there, right, with the rectum and the urinary bladder, and lower limbs are involved. And when we come to cauda equina syndrome, usually sphincter don't suffer, because usually for sphincter problem there should be bilateral lesion. Write it down please. For sphincter problem there should be bilateral lesion. So cauda equina, when it is a unilateral problem, sphincters are not significantly affected, but motor and sensory problems in the lower limbs are there. Irritative manifestations will be there, and eventually destructive manifestations will be there. Now we come to, this is our 27th case. Now let's do some few more cases related with the lesions in spinal cord. Now we are going to talk about an interesting situation in which there are basically degeneration of white matter in spinal cord. Let's suppose it is here. What was this? Fasciculus, and here it is cuneatus. Again there is gracilis and cuneatus. Now the disease which we are going to discuss now, actually this is produced due to deficiency of chronic deficiency of B12, right? Vitamin B, chronic deficiency of vitamin B12. When there is deficiency of B12, everyone knows that B12 plays a role in along with the folic acid in hematopoiesis and proliferation of skin cells and proliferation of GIT lining. But B12 has another special function in maintenance of myelin sheath. So when there is in pernicious anemia, suppose when there is chronic deficiency of B12, not only the megaloblastic anemia, megaloblastic macrocytic anemia, but there may also be neurological dysfunction, and in this neurological dysfunction, ascending and descending tracts which are heavily myelinated, they undergo demyelinating problems, and this is called subacute combined degeneration. Condition is called subacute combined degeneration. Why we call it combined degeneration? Very good, both ascending and descending systems are involved. Dorsal column systems are involved. Then what was this? Anterior and dorsal and ventral spinocerebrals, they are also involved. And here it was, what was this? Spinothalamic lateral and anterior spinothalamic, and here it was downgoing. What were these? Corticospinal, lateral corticospinal. Now, what really happens in this case? Number one, grey horn is spared. Anterior grey horn as well as posterior grey horn, it is not affected, right? Problem is, number one, with the dorsal column, and dorsal column sensations are bilaterally may be lost, right? So which sensations are lost? Tactile discrimination, fine touch, vibration and sense of position. Along with that, spinocerebral system, when it is disturbed, there may be dystaxia. If dorsal is disturbed, there is ipsilateral dystaxia. If ventral is disturbed, contralateral lower limb dystaxia. With that, if there is also involvement of, you can say, corticospinal pathways which are descending, it means upper motor neuron type of lesions are seen for the muscles. So if there is a bilateral problem with the corticospinal pathways, because these are also very heavily myelinated, so deficiency of B12 will also disturb the quality of myelination of these tracts. So lower motor neurons will be released from the inhibitory effect of upper motor neuron. So you may find there is hypertonia or spasticity or spastic paralysis, you can say, and hyperreflexia may be there. So these are the problems seen usually in subacute combined degeneration. Now, another situation which is there is, okay, in this situation, lower motor neurons are intact. Problem is with corticospinal, it may be degenerated. Problem is with cerebral Purkinje cells, they may be degenerated, and problem may be there related with the spinocerebral pathways. Spinocerebral pathway, they may be disturbed. Of course, when upgoing fiber for the cerebellum and outcoming fibers from the cerebellum both are disturbed, patient will have severe ataxia, incoordinated gait, right? And this condition, if it is inherited, the commonest cause of inherited ataxia is Friedreich's ataxia. Commonest cause of inherited ataxia is ataxia, right? Now in Friedreich ataxia, what is the real problem? In Friedreich ataxia, this is the most common hereditary ataxia with autosomal recessive problem. It means defective gene has to come from mother and father both. then the index case will suffer with the problem. Because in case of recessive diseases, paternal and maternal both copies should be defective. In case of dominant diseases, either parent may give one copy defective and disease manifestation may be there. Because Friedreich ataxia is autosomal recessive disorder, it means that if defect come only from the mother or only from the father, patient may be carrier but will not be sufferer. But when they are close marriages and defective gene is moving in the family, right? In this case, family is making a abnormal protein called frexatin, right? This is due to